Hello everyone, I am Dorina Esendagli and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I am a part of the editorial board of the ERS Monograph as the early career member of the ERS. I'm here today with the two guest editors of the recently published monograph on the digital respiratory healthcare. Hilary Pinnock is a professor of primary care respiratory medicine at the University of Edinburgh, UK. She is the co-lead of the ERS Clinical Research Collaboration Connect, which focuses on implementation of the digital respiratory care, and she's also the chair of the Education Council of the ERS. Vitalii Poberezhets is an assistant professor at the Department of the Prosthetics of Internal Medicine at the National Pirogov Memorial Medical University in Ukraine. He is an adult pulmonologist and clinical researcher with a particular interest in airway diseases. Welcome to both of you. So I'm very curious to know for both of you, how did you get involved in the digital healthcare? Can you tell us about that? Hilary?
Okay, well, I guess over the last years that I've been working in healthcare, digital care has just gradually come into our way of life. My real interest in research is around how we implement new innovation, how we deliver care. So, of course, as digital healthcare has become part of our world, it has also become part of what I have started to research. And over the years, I've done work in reviewing asthma by phone. I did that nearly 20 years ago. So that was the first time I started looking at that. More recently, we've started looking at video and asynchronous consulting. I've looked at preventing admissions in COPD with monitoring, diagnosis using decision support systems. Basically, when we then hit a COVID pandemic, even more, I found myself involved with delivering care through digital means. So it just seems a natural progression from my interest in implementation research.
And talking about myself, I was quite interested in this topic even when I was studying in the university, as I found a lot of perspectives how to use digital technologies in health. And then when I was start working as a pulmonologist in my home city, I started using different e-learning resources for patients with bronchial asthma to improve the literacy. And I saw a huge effect on this. And after this, when I was attending ERS congresses, I started communicating with the clinicians from other countries about this topic and find out that there are a lot of people also interested in this. There's a lot of things done. I was really happy that ERS launched eHealth and Health Group in 2019. And I applied myself as chair of this group because I believe that I had a lot of new ideas and visions how to improve digital strategy of the ERS. And it was a pleasure for me to be elected and to act as for several years as chair of this group. And after this, I fully agree with Hilary that COVID pandemic, it just pushed ourselves into the digital world more, and the world will never be the same as before the pandemic. So digital health, it just moved step forward.
Well, yeah, really, I also agree with that. We are kind of obliged to know about the digital healthcare and to be involved as healthcare professionals. But what does technology actually do? How does it help us, especially in the respiratory care? Can you give examples of the practice in the clinics?
There are so many examples, Dorina. It's hard. Yeah. It's very difficult to know where to begin. And one of the things we did in the monograph, if you look at the first few chapters, we tried to look at some of the range of technologies in the first 6 chapters. And, you look at what they call the medical Internet of Things, where we can bring all sorts of devices and data, and we can personalize these for the patients in front of us. I enjoyed learning about medical assisted robots. Amazing what we can now do for people in their homes. Then, of course, you start thinking about artificial intelligence, and we're all talking about that at the moment, and how that can help us assemble information and help our patients to understand information, help us to process information. I can always see the public health value of all these data so that we can actually begin. We saw it in the pandemic, of course, hugely, where we use these big data to manage the pandemic. But we can also look at outcomes for all sorts of conditions and perhaps target care. I see it also underpinning a lot of algorithms. I'm very interested in supported self-management. and how it can underpin the algorithms that we give people who are living with a condition like asthma or COPD. I mean, the list goes on. It's absolutely huge. Remote supervision of conditions like, for example, pulmonary rehabilitation is delivered remotely. Looking after people with sleep apnea, we've been delivering remotely. All of this is happening. What is really, really important, though, of course, is that we won't realise this potential unless we work out the challenges of implementation. We've got to work out, and that's what's so exciting about this area, is that we are at the point of actually now being able to shape how we implement this for the benefit of the patients.
Yeah, I like just to add that I really get stuck when someone asks me, like, give a simple structure of digital health. It is quite difficult. It's so huge and so various fields of digital health. So even if talk about AI, there's so many subfields. So it's the greatest for me question, and the basic question for digital health is how to structure this into some fields, because it also interacts too much between each of them. But fully agree with the Hilary mentioned, and like to add that also there is for instance, from my perspective, what I see in my country right now is telemedicine solutions for consultations of remote consultations of patients, of consultations between clinicians, healthcare providers. There is like a huge field of this, and it's constantly growing.
Yes, it's quite broad, and actually I don't know how it is standardized in many places, in many countries, because when we talk about digital healthcare, I think there are still some gaps on definitions about this. But I'm very curious to know, what do you think? Is the digital healthcare safe, actually, because we are going to use it a lot in the future? And which are the groups of patients that are specifically more profiting from this application?
Again, it's not easy to know where to start. Let's take the first question, shall we? Let's take the safety issues. I picked up, when I was scanning through the monograph earlier on today, I picked up a quote from Brigitte Foreau in her chapter about regulation. A remote approach can enable earlier access to sleep professionals. It saves travel and costs and less missed time off work. So, the point she was making is how much benefit there is there for people. But we also need the safety aspects of this. It seems to be so good, but what about the safety? And we have one of the chapters, again, about regulation. Devices are very well regulated. They have to be safe to perform and benefit patients. And regulations must allow good innovations to reach patients, but they must also be adapted to the patients and the market needs. And that implies also that there has to be some oversight from people in order to manage the safety aspect. So it's good to be enthusiastic, but it's also important to be regulated. Vitalii can probably help with that.
Yes, it's really a nice question, a tricky question, because those who get more involved in digital health, these people and these clinicians, they understand that, for instance, if you talk about like AI and machine learning, this algorithms requires huge, large database of healthcare information, healthcare data from the patients, and this is sensitive information. But it is required for these algorithms to create some feedback, to work properly. AI could not learn without this huge databases. And this is like a threat that some data from the patients could leak into the wrong places. And data safety, there is an issue, because if you would like to teach machine learning, teach AI more effectively work, we create large databases, more threads, that's something could change. So it's like we should always compensate this with safety, some actions that we do. But I'm not telling that digital health is dangerous because of this. No, this is what we should take into account, and this is what we must understand. So if we use more data, we must always remember about security. Another issue that Hilary mentioned, Internet of Things, it requires that the data should have nice interoperability. So data could be easily, safely exchanged between different systems, different devices, and it also should be done with all the safety requirements, and we must regulate this and must remember about this. So yes, there is a danger, but if it is created correctly, nothing to worry about.
It is, of course, a worry that you bring up, Vitalii, that the patients always, when we talk with patients about these types of digital world, where is my data going? And there are concerns about it from the patients. So, it's so important. They want their data shared. They want their data used in this way, but they want to be sure that it's absolutely secure. So it's a really important point that you're raising there.
And what about the specific groups of patients? Who do you think will profit the most? Or everyone, maybe?
Yeah. Do you want to start on that, Vitalii?
Of course, I believe that everyone will benefit from this. Because digital health, it provides perspectives and new solutions for everyone. So there are some concerns about low digital literacy among some groups of patients, or some resources, or some countries with low middle income countries that is not wouldn't work so much in these countries. But there is always some digital solution surrounding the situation. So of course, if patient has low digital literacy, he has less access to some digital solutions, but we could use other solutions like remote monitoring the patient, which does not require some action from the patient, active action from the patient, and we could win this situation. So I believe everyone could benefit from this. But the trickiest part is for us and for the healthcare system to create and adjust digital health solutions for this group of patients.
Well, yes, I was thinking back to when we started to develop the plans for this monograph, and we had to decide what chapters to put in. And as you can imagine, with all the possibilities, it was quite difficult to work out what we were going to feature. We actually have structured the monograph so that there are 10 chapters towards the second part of the monograph, which actually look at some very specific examples. So a specific group of people, perhaps with TB or people with asthma or with sleep apnea, or who want to support themselves to stop smoking. So we looked for these groups, and then we looked for some of the technologies, and we sort of did a bit of a mix and match so that we tried to represent as many different groups as we could, as well as many different technologies. But it's important to recognize that we had 10 chapters, but they are only examples. We could have covered many more topics. We could have mixed and matched them in very different ways. The message really is that I think whichever area of medicine, but respiratory medicine we're talking about today, digital transformation is coming. It's not a question of if it's going to happen. It's more a question of how it's going to happen. It's already happening. It's already beginning to support our work, and it's going to more and more and more. That's why it is so difficult to answer your question about which groups of patients, because I think it's going to be all of us.
Yes, I also do think that everyone will profit from this, but maybe it will be crucial for the ones that cannot come to the hospital, cannot come to the doctor especially. So it might be, an option for everyone, but maybe really important for some specific groups like the older adults, or maybe the ones that have multiple comorbidities and cannot walk or cannot come to the hospital. But as Vitalii told, there are some problems, I think, in implementing this digital healthcare, because there will be additional costs. And for low and middle income countries, this might lead to maybe inequity to healthcare.
Oh, gosh, another really huge question. If you look at the WHO literature, they consider digital health as being an essential component of achieving universal health coverage. So for them, it's actually increasing equity in the sense that it allows people who hitherto have not had access to healthcare to access healthcare despite living in extremely remote or difficult places. So they see it as absolutely crucial to improving equity. The question, however, is whether it will be an equivalent to the healthcare that's delivered face to face, maybe better than what they've got, but is it actually equivalent? And there are some challenges in lower middle income countries, and we covered this in a couple of our chapters. There are some real challenges. For example, if you're going to use digital healthcare, you need the infrastructure to do that. You need electricity reliably.
Yes.
You need a signal for your mobile phone. You need a phone. Now, you may well have a phone in your family, but it may well be used and owned by young male worker, so that the elderly female who has comorbidities and a lot of problems may be the one person that doesn't get to use it. So, there are challenges there. I think also there are challenges around legacy technology. Technology has a habit of moving on and changing, and we all know the frustrations of a new upgrade on our computer system, and now it won't talk to the printer. So we have these similar problems where technology is updated and now it doesn't work with last year or even last decade's mobile phone systems. So adapting the technology so that it can actually work with these old systems can be really important in some either low and middle income countries or indeed in deprived communities in high income countries. We have to think about visual problems, people with hearing problems. Mobile phones are really very small for looking at information on it. So providing something that's really big. When we worked with COPD many years ago, we had a technology that was absolutely huge, the size of a laptop, size of a computer, with big words on it so that people could see it really clearly. So we have to adapt to make sure that people in these potentially disadvantaged groups are actually able to overcome the problems. And then there are difficulties around cognitive impairment. If you are, getting older and you're finding it hard to learn new tricks, then digital technology will require somebody else to actually help you with it. So that's a real problem if you are working in a digital by default situation, as we were in the pandemic, where you couldn't go to see somebody for infection control reasons. But if you were struggling with technology, that could be a real problem. On the other hand, it was hugely advantageous because we had people in residential homes and we were able to do our ward rounds in residential homes by using a laptop that the nursing staff took around the home and helped the elderly people to manage it. So it can be overcome, but yes, there are challenges of inequity.
I'd like to add about low and middle income countries. So I think that's a nice example of how it really works. It's not about respiratory medicine. It was like an automatic system, AI ophthalmoscope to assess changes on the retina of patients with disease, which is implemented by one company in rural areas in Africa. So as the idea, why they created this and why they implemented this in these areas? Because in such resources, such communities, there's always lack of costs for the healthcare, and people don't receive the proper healthcare. And by creating such automatic system, which assess the eyes of the patient, they were able to cover so many patients that their healthcare systems, all of the ophthalmologists will not be able to cover many, many years. So the idea is that if we create some automatic systems that will help clinicians in such resources, provide care for a more amount of people without spending too much cost on this, I believe that it will work. For instance, what I see in my own resources, so currently in Ukraine, we don't have so much resources that we could spend on the healthcare, on our other fields that is important, but we have now more important field to involve this cost. And we have a really nice example here of remote spirometry. There are like there's a combination of telemedicine and remote monitoring of spirometry of patients implanted in our region, and it works greatly, especially in some rural regions. I agree with Hilary that indeed it is required to have like nice internet connection, stable electricity, and right now it's sometimes there could be issues with this. But of course, we should take into account this when we create this telemedicine station, that it must work with like not the perfect connection to the internet. Maybe there could be like an additional source of energy for this solution. So we could create something that will work in different areas. So I believe that digital solutions could develop in low and middle income countries. And I believe even the result will be much more higher, even if we're talking about compared with other countries.
I think you've raised a really interesting point there, because it's how it's designed. It has to be designed with the end user in mind. And with one of the chapters that we've included, looks at this issue about achieving equity by co-designing with the population who are going to use it. And if, as you say, electricity is the problem, then that needs to be built into, or if visual issues are the problem, that needs to be built into the system. And it's a question of co-design.
So I'm very curious to know about the ERS CRC, the Connect study that you have. What is it about, and can you tell us about the short and the long-term plans that you have for this collaboration?
Yes, I can. A CRC stands for a clinical research collaboration, and these are funded by the European Respiratory Society, and their aim is to encourage a network of interested people to get together, to talk together, and to further some research in a given area. The Connect CRC is interested in how we implement digital healthcare, so it's very relevant to all the topics that we've been talking about. It is a very large global network. We have over 900 members from 83 countries at the moment, multidisciplinary, and many of the things that we've talked about today, implementation strategies, the challenges, ensuring equity, are all part of our interests, and we've got systematic reviews ongoing. We're developing policy position papers. What we're trying to do is set some foundations so that moving forward we can actually implement digital healthcare for respiratory care. Very much what I was saying, we have to grasp this agenda, and this is hoping to set the foundations of that.
To summarize, what is the take-home message from this monograph that you would like to send to all the listeners of the podcast?
So I would like to say that this monography is like a toolkit for different stakeholders, for clinicians, for healthcare providers, for various countries, for patients, for their relatives, for politicians, and some structured digital health. And it's like one small part of all the solutions that could be implemented. And it get updated every day. So we created this monography, and now I see that some chapters could be updated. So some new information appeared. So don't be afraid to implement digital health, and use this monograph as a toolkit for this. That's my take-home message.
I think mine isn't too dissimilar. I mean, I think what's come out of this for me is statements like digital transformation is already happening. It's not a question of if, but how. It's how do we implement this? And I think the message from my point of view is that as healthcare professionals, or indeed as patients and families of patients, we must engage with this. It's no good leaving this to engineers or politicians or anybody else. We need to engage with this. We must recognise it's complex and it's ever-changing, and we've got to think about the pros and cons and balance these pros and cons that we've been talking about so that we offer more functionality for our patients and don't lose the things that we value in the care. We haven't had time to talk about the relationship with clinicians and the empathy and how we can keep that going in the context. So this is complex, it's nuanced, but as healthcare professionals, we need to lead this transformation. And I agree with you, Vitalii, the obvious start for that is to read the monograph, because it provides a very broad range of ideas and describes the sort of state of the art as it is at the moment. There are a lot of digital health concepts, ideas, and will give people a good start in the respiratory digital health landscape.
Well, I also think that we should take advantage of the digital healthcare, and we have to improve the respiratory health in each step. It will improve it in the diagnosis, in the treatment, in the follow-up, and also will bring it in an upper level, we hope, in the future. So as you also said, we encourage all the listeners to read the monograph to get a broader information about this topic. And I thank you, both of you, to be here today, and all the listeners that were with us in this podcast. Thank you very much.
Thank you.
Bye.
Bye.
Bye-bye.